Okay, welcome back. This is session 6 or part 6 of the specialized nutrition support session for Skills Lab, and I think this is going to be the last session or last part, believe it or not. We're almost done. So we left off talking about enteral nutrition, and I mentioned that there were standard formulas and other formulas or disease-specific formulas, and they all have their little twists and nuances. But honestly, most of the time, we in the hospital anyway, we end up using standard formulas, maybe a slightly modified standard formula, meaning that it contains extra protein, and this helps us get to that 1.3 to 1.5 grams of protein per kilogram per day, because otherwise most standard formulas typically have about 1 gram of protein per kilogram. So we'll have to add a little extra protein powder to get them to their protein needs if we use those. And just also FYI, most standard formulas provide 1 kilocalorie per every milliliter of volume that the product has. So if you're giving somebody 240 milliliters or 1 can of the formula, that would typically give them about 240 calories. Okay, so a few things about oral formulas versus tube feedings. And if we go back 2 slides, you can see this is a tube feeding formula down here. This is something more intended to be drank by the patient through the mouth. And so these the oral formulas have a much better taste. You might taste one Ensure, Boost, and say, I don't think it tastes good. But if I was to let you taste a tube feeding like one of those other products, you'd be like, oh, that's disgusting. So there really is a difference in palatability. And then the container size, you can see, again, going back, this is about a liter bottle intended for tube feeds. Most of these other products that are intended for oral consumption are usually in these small cans, about 240 mils. And then are also the things for tube feeding are more difficult to obtain. You usually have to go through a home health company versus like your Walmart or Walgreens even, where you can get some of the things Boost and Ensure. Even Kroger has those types of things. But the specialized formulas usually have to go through a home health. Okay, then there's the issue of continuous versus bolus of tube feedings. Bolus meaning you open up a can and literally pouring it down the tube. 1 to 2 cans every 4 to 6 hours, something like that. Kind of more reflecting of the way we normally eat. We eat a hamburger or Happy Meal or whatever, and we're done with it after 20 to 30 minutes, and then we wait till the next meal. So that would be what a bolus feeding is. Continuous feeding would be kind of like the TPN, where we run it continuously through a feeding pump into the patient's GI tract. So from an outpatient standpoint, as you could imagine, bolus feedings would be much more convenient. Again, it mimics our normal way of consuming food. But from an inpatient standpoint, although bolus feeding sometimes used continuous, it's usually associated with better tolerance, especially when you're starting somebody out. So it's much more common on an inpatient basis to use the continuous enteral feeding. And also, if you're doing bolus feeds, there's no need for an infusion pump, which is an extra charge to the patient and a little inconvenient at home. So that's where convenience comes in, having to have the pump at home, being hooked up to the infusion pump the whole time. It's very inconvenient for a patient, but bolus feedings are much more convenient. And then with jejunal access, again, sometimes we feed into the stomach, into the duodenum, or even if we have a long enough tube, it goes all the way into the patient's jejunum. And in that case, the continuous feedings are better because it's such a small diameter down there in the jejunum that bolus feeds tend to cause cramping and some other problems. So it's difficult to do bolus feedings into the jejunum. All right, quickly talk about the complication. Probably the most significant complication with enteral nutrition, that's aspiration. This is the most serious complication. It's common in an intensive care unit because patients are sedated. They usually don't have a gag reflex. They've got a ventilator tube going down their throat. Clinical consequences can be variable, but can end up in pneumonia, and it can even cause death and other respiratory problems. So again, in the ICU, normal defenses like the gag reflex are compromised because of sedation, paralysis, and the presence of endotracheal tubes. So again, aspiration is where, let me show you here, we go into the patient's esophagus with a feeding tube, and it's supposed to go in the stomach, well, or the duodenum. But if those contents, for whatever reason, kind of make their way back up here, and you can see there's a junction right here between the trachea and esophagus, and if the tube feeding contents find their way into that patient's lungs and pick up bacteria along the way from the throat or oropharynx, can cause aspiration pneumonia, and that can be, of course, life-threatening. This is a little bit better picture to kind of see trachea and esophagus, and when the tube feedings come back up, it's very easy for them to go back into the trachea and end up downstream into the lungs. So some things that are associated with being risk factors for aspiration pneumonia would be if the patient had documented previous episodes, if again the gag reflex and so forth is compromised via decreased level of consciousness, and usually that's induced by drugs or could be related to their condition or disease. Neuromuscular disease, endotracheal intubation, if they have a lot of vomiting or nausea, regurgitation, the reflux, any of those problems are likely to bring up stomach contents to where they can end up in the lung. If they're prolonged in the supine position, laying down, it's again kind of related to reflux if you think about it. And then another risk factor would be persistently high gastric residual volumes, and that's those gastric residuals I was talking about, where the nurse actually pulls back on the feeding tube and can measure how much fluid, feeding, gastric juices are in the stomach, and they should be low, less than 10 cc's optimally, but if they tend to be high, around like 150 mils, 200, that kind of gives you an indicator that things aren't passing on through into the duodenum, into the jejunum, so they might have some issues with GI tract function. So some strategies to prevent aspiration include elevating the head of the bed of the patient by 30 degrees, and all of these hospital beds have the little built-in things where you can elevate head of the bed, and sometimes the part right under the knees. So that's good to do that. Tube placement is important as well. Sometimes the tube is in the esophagus, which is the worst part, versus it going down a little bit further into the stomach. A little bit better, but small bowel is optimal. So again, looking at this picture, if you put a feeding tube in the mouth, goes down the esophagus, if it ends up, the distal opening is here, and that's where the tube feeds are coming out of the tube, that's not good because they're going to come right back up. You want it to at least be in the stomach, and preferably even further down through the duodenal sphincter and into the duodenum or jejunum even further down. So again, monitoring of GI tract motility. Sometimes we use prokinetic agents to facilitate that. And use of a small bore feeding tube is important as well. The typical NG tube, nasogastric suction tube, is really a large bore tube, and it causes too much pressure on the esophageal sphincter, and it makes it easier for things in the stomach to find their way back up the esophagus. Subglottic suction is a technique that the nurse uses to suction things off from the oropharynx, and oral care as well. So these two things here, in oral care by the nurses, where they clean it up with an antimicrobial solution in the patient's mouth, because if the patient does aspirate and the contents of the feeding in the stomach come up the esophagus, find their way, kind of mix with the oropharynx and then go to the lungs, if the suction and oral care are in place, it's much less likely that the contents from the stomach are going to carry bacteria with them into the lungs, and so it decreases the chance for aspiration pneumonia. So 96% of hospitals use gastric residual volumes as the prime determinant of enteral nutrition tolerance, and most will use a threshold of 150 mils for stopping enteral nutrition, meaning if the nurse measures there's greater than 150 cc's of gastric residual volume, then that indicates that things aren't passing on through, and so it's time to stop the tube feeds. But that number, these thresholds vary widely even within a given hospital. And that concludes the specialized nutrition support presentation. So I hope you've learned something, and if anybody has questions, please contact me. Thank you very much for listening.